All right, so what I want to talk about just in the next 5 minutes is about vision rehabilitation, and it's the thing that we can do right now. So we've got lots of research going on trying to cure disease, but what do we do for people who have experienced a loss of vision right now? How do we help them function better? And so what we're going to talk about very quickly is what low vision is and vision rehabilitation, the goals that we have for vision rehabilitation services. I'll briefly show you some of the different treatment modalities that we use to enhance visual functioning, and also talk about one of the major barriers that we face every day to vision rehabilitation. So low vision is a term that you hear around. What it really means, it used to be a number, but now what it means is how a person's vision is affected. So somebody who can't be fixed with medicine, surgery, glasses, contact lenses, who has reduced vision that affects their ability to function every day. So it doesn't matter what the number is, it matters about function. We're trying to improve the quality of people's vision so that they can function better. And visual impairment causes lots of different problems. So it problems with reading, with driving. We spend a tremendous amount of time dealing with issues surrounding driving with a vision loss. We're a rural state. Not being able to drive is a bad thing for a lot of people. You know, but even meal preparation, just personal grooming, those things. And of course, ultimately it leads to loss of independence, which is the big concern for people. Economic impact of vision loss, $51 billion a year in 2007. So huge numbers huge problems related to the loss of vision. So, you know, you think about rehabilitation. If somebody says rehabilitation, you think about somebody who's lost an arm or a leg, and they're getting fit with a prosthesis, or somebody who's had a stroke and they can't speak, and they go to the speech therapist and learn how to speak. But we don't think about it as much in terms of vision loss. And we do the same thing. We try and maximize function to improve the quality of life of people who have experienced a loss of vision. So that's what vision rehabilitation is all about. It's part of the continuum of care. So it's not just, you know, that's all we can do medically or surgically. As Dr. Stone says, there is something we can do, and this is part of that continuum of care. And I have the good fortune of collaborating with all the services in the Department of Ophthalmology, because there's, you know, all different kinds of vision loss and all different types of problems, and we try and help maximize the function for all those folks. So our goal is just that, to maximize the function. That's going to enhance potential, increase the independence, and ultimately improve the quality of life of every person who has a vision loss. Now, there are a variety of different prescriptive treatment options. I wanted to show you these real quick. So reading glasses. You know, we think about glasses as just, you know, plus or minus lenses, but special reading glasses, we do have to hold things closer. We use what's called relative distance magnification, and so that doesn't work the best for everyone. But stronger glasses require you to hold things closer. Magnifiers we're all familiar with, but typically the ones that you get in the store are going to be bigger and not quite strong enough. So the stronger they are, the smaller they become. Telescopic devices, which can be used handheld or spectacle mounted for distance or near vision enhancement. In some states, these are used for driving as well. This is a picture of a young man I saw in Micronesia. He has Pingliapes achromatopsia, so he has no functioning cones, and he's extremely light sensitive. And with these special filters, you can see that now he can open his eyes in a room like this and be much more comfortable. So one other tool that we use. This young lady was getting ready to go to college, was looking at electronic magnification to help her to see better so she could do the studying she needed to do. On the right is a picture from an artist who hadn't been able to paint for 2 years, and then got one of these devices, and in the first week she had it, was able to paint this rose, which she brought to me, so very exciting. And this gentleman, I just looked up his age. He's 84 years old. He's a patient of Dr. Stone and I. He's a structural engineer. No longer drives. He has a driver, but he still consults at construction sites and uses this portable electronic magnification device to be able to read blueprints and other things at the job site that he needs to read. We have head-mounted devices. We have these at Hampshire, thanks to a grant from the Carver family. But people use these for distance and near vision enhancement. So a thing called Geordi, loosely named after Geordi LaForge from those who remember Star Trek days. And computer accessibility. So computers have been a great benefit to lots and lots of people, and there's lots of accessibility options available on computers to help people with vision loss function better. So what's the barrier to care? The barrier to care is funding. No insurance pays for these tools. So we have tools that are available to help people function better. Medicare, Medicaid, most regular insurances don't pay for these things. And that's what makes philanthropy so important.